Welcome to Sports Science Insight, the channel where we break down scientific evidence and turn it into practical knowledge for training, rehabilitation, and human performance. Today, we are looking at the article, Blood Flow Restriction Training Improves Strength, Fatigue, and Function in Middle-Aged Adults with Multiple Sclerosis. This randomized controlled trial was published in the Journal of Science and Medicine in Sport in 2026 by Cano-Sánchez and colleagues. The study asked a very practical question. Can people with multiple sclerosis improve strength and function using low-load resistance training with blood flow restriction? The answer from this trial was promising. After 12 weeks, the BFR group improved strength, fatigue, physical activity, disease impact, and manual dexterity. But this is important. This does not mean BFR cures multiple sclerosis. It means that, in this trial, supervised low-load BFR training helped improve several functional outcomes in middle-aged adults with MS. And if you want more evidence-based breakdowns on rehabilitation, exercise physiology, sports science, and human performance, subscribe to Sports Science Insight. Multiple sclerosis is a chronic disease of the central nervous system. It can affect movement, strength, fatigue, coordination, independence, and quality of life. For many people with MS, fatigue is one of the most limiting symptoms. The article notes that chronic fatigue affects more than 80% of people with MS. This can reduce physical activity, increase deconditioning, and make daily tasks more difficult. Muscle weakness is also common, especially in the lower limbs. And manual dexterity can be impaired, making simple daily activities harder, such as writing, dressing, or handling small objects. Resistance training can help people with MS. But there is a challenge. Traditional moderate to high-load strength training, around 60 to 80% of 1 RM, can be difficult for some people with mobility limitations, fatigue, and reduced functional reserve. That is why low-load strategies matter. MS needs effective training with lower mechanical stress. This study was a randomized, controlled, clinical trial. At the beginning, 76 individuals were contacted. Of these, 69 participants were randomized into 2 groups. The experimental group received BFR training. The control group continued with usual care. After follow-up, 32 participants were analyzed in the BFR group, and 33 participants were analyzed in the control group. The intervention lasted 12 weeks. This design is important because it compares the BFR program against usual care over time. It allows the researchers to evaluate whether the changes were greater in the group that received the supervised training program. The participants were assessed before and after the intervention. The researchers measured disease impact, muscle strength, fatigue, physical activity, and manual dexterity. So this was not just a study about muscle strength. It was a broader clinical trial about function and daily performance in people with MS. This was a randomized controlled clinical trial. The participants were middle-aged adults with multiple sclerosis. They were between 40 and 65 years old. The mean age was about 51.8 years. They had an expanded disability status scale score below 7, with a mean score around 3.9. This means the participants had real functional limitations, but still had enough autonomy to take part in the training protocol. Another important detail is that participants had not taken part in structured exercise programs during the previous 6 months. This matters because the study was not testing highly trained people. It was testing a group that better represents many clinical rehabilitation contexts. These were adults with MS, fatigue, weakness, and functional challenges, but with enough capacity to perform supervised exercise. The study also excluded participants with contraindications to BFR or physical testing, such as uncontrolled cardiovascular conditions, thromboembolic history, peripheral vascular disease, severe renal impairment, local infections near cuff placement, recent MS relapses, or other serious medical concerns. So the population was selected carefully for safety. Middle-aged adults with MS and real functional limitations. The BFR group completed a 12-week supervised resistance training program. They trained twice per week, on Tuesdays and Thursdays. That gave a total of 24 sessions. Each session lasted about 40 minutes. The structure was simple. First, a 10-minute warm-up with joint mobility exercises. Second, a 20-minute main strength section. Third, a 10-minute cool-down with stretching and breathing exercises. The program separated upper and lower body work. Upper body training was performed on Tuesdays. Lower body training was performed on Thursdays. This split was chosen to reduce total fatigue per session and improve safety. The exercises were single joint movements. Upper limb exercises included biceps curls and triceps extensions. Lower limb exercises included leg extensions and leg curls. The authors selected single joint exercises to reduce global fatigue and make the protocol safer and easier to reproduce in clinical settings. The load was only 30% of 1 RM. So the key idea is strength training without heavy loads. Blood flow restriction was applied using pneumatic cuffs. The cuffs were placed near the top of the limbs. For upper limbs, they were placed below the axilla. For lower limbs, they were placed below the gluteal fold. The study used individualized pressure. This is very important. The key point is not the formula itself. The key point is that pressure was adjusted on limb size and blood pressure, instead of applying the same pressure to everyone. The study estimated arterial occlusion pressure, also called AOP. Then, during training, the relative pressure was applied according to the limb. For upper limbs, the pressure was set at 40 to 50% of AOP. For lower limbs, it was set at 60 to 80% of AOP. The protocol also used intermittent BFR. That means the pressure was released during rest periods. This can improve comfort and adherence, especially in a clinical population. So the practical message is pressure was individualized, not guessed. And this matters because BFR should not be applied casually. It needs screening, supervision, and appropriate pressure control. The researchers measured several outcomes. First, they assessed the perceived impact of multiple sclerosis using the MSIS-29. This tool evaluates physical and psychological aspects of the disease. Second, they measured muscle strength. They used 1 RM tests, hand grip strength, and the 30-second sit-to-stand test. Third, they assessed fatigue using the fatigue severity scale. Fourth, they measured physical activity using the International Physical Activity Questionnaire, or IPAQ. Fifth, they evaluated manual dexterity using the 9-hole peg test. This test measures fine motor coordination and is especially relevant for people with MS. It reflects abilities needed for daily tasks, such as manipulating small objects, writing, and using the hands efficiently. So the study was broad. It measured strength, fatigue, activity, and daily function. That is important because a rehabilitation program should not only make someone stronger in a test. It should help improve the person's functional capacity and quality of life. The main results were positive for the BFR group. Compared with usual care, the BFR group improved across all measured outcomes in this trial. Strength improved. This included upper limb strength, lower limb strength, hand grip strength, and sit-to-stand performance. Fatigue decreased. This is clinically relevant because fatigue is one of the most limiting symptoms in multiple sclerosis. Physical activity increased. This suggests that the program may have helped participants become more active beyond the training sessions. Manual dexterity improved in both hands. This is important because hand function affects daily autonomy. The perceived impact of MS also decreased, including physical and psychological domains. Another important finding, no adverse events were reported during the intervention. So the message is BFR, improved more than strength. It was associated with improvements in fatigue, activity, dexterity, and perceived disease impact. But we should still be careful. These results come from a 12-week trial, and longer-term follow-up is still needed. Why might BFR help in this population? The article discusses several possible explanations. Low-load BFR can create high metabolic stress without requiring heavy mechanical loads. This may stimulate fast-twitch muscle fiber recruitment. It may also support hypertrophy-related signaling, neuromuscular adaptation, and better motor coordination. For people with MS, this is important because heavy loads may not always be well tolerated. BFR may allow a meaningful strength stimulus with lower external resistance. The study also suggests that improved strength and function may reduce fatigue perception. When people feel stronger and more capable, they may move more confidently. This can support physical activity and daily function. Manual dexterity improvements may also be connected to better hand grip strength, improved motor control, and more efficient neuromuscular coordination. But we need precision. These mechanisms may help explain the results, but this study did not directly measure all of them. So they should be understood as plausible explanations, not confirmed mechanisms from this trial alone. BFR may support both muscle and function. So what should we take from this study? First, low-load BFR may be a useful alternative for people with multiple sclerosis who struggle with heavy resistance training. Second, in this trial, BFR improved strength, fatigue, disease impact, physical activity, and manual dexterity. Third, the protocol was supervised, individualized, and screened for contraindications. That matters. BFR should not be treated as a simple shortcut. It requires pressure control, professional supervision, and safety screening. Fourth, the results are promising, but they are based on a 12-week intervention. Future studies should examine whether the benefits last over time, whether BFR can be combined with other exercise methods, and whether it affects biomarkers of MS progression. The final message is simple. Rehab gains do not always require heavy loads. For some clinical populations, the right low-load strategy may be enough to produce meaningful, functional benefits. If this video helped you understand how BFR training may support rehabilitation in multiple sclerosis, subscribe to Sports Science Insight. Here we analyze scientific evidence and turn it into practical knowledge for students, coaches, clinicians, and anyone interested in evidence-based performance and rehabilitation. Leave your comment below. Would you consider BFR as a rehabilitation tool for people who cannot tolerate heavy training? Thanks for watching, and I'll see you in the next breakdown.